All right, here we go. Integrating food as medicine. I'm your host today, your trainer, clinical nutrition training overview. And we're going to do purpose, goals, objectives, brief overview of Recipe for Health, clinical nutrition training. A little background on me. I'm a family medicine doc and the chief medical officer for Alameda County's Recipe for Health program, and been doing food as medicine type work ever since my fellowship in integrative medicine, but really the opportunity to scale this work across Alameda County and the clinics since 2016 at Hayward Wellness as the medical director, and then more recently at the county, kind of growing it across partner FQHCs. So excited to be here with you all. Purpose and goals: to equip you, clinicians, prescribers, with food as medicine tools so that you can, at the end of the day, improve health outcomes and food and nutrition security. The objectives are really simple. There's three objectives you're going to gain from today's training. Describe 3 paths to healthy eating: the when, the what, and the how to eat, and identifying where your patient is on these paths. And so think about it as a path, and that patients can jump paths, and you can jump with them in the middle of a clinic visit. And then there's the steps. There's 6 steps that you can take to help your patients on the various paths to healthy eating, really to lower insulin resistance and inflammation at the end of the day. And then to increase the Recipe for Health referrals. Ashby's clinic goal is 35 referrals per month. And Lifelong as a whole system will be 70 when other clinics within Lifelong join. I want to give you a national, state, and local update. In September, I was at the White House Conference on Hunger, Nutrition, and Health. It's the first time they've held it in 53 years. And it's massive, and it's a whole society approach. The White House has a bipartisan strategy to get food as medicine reimbursed by Medicaid and Medicare. Reimbursed by Medicaid and Medicare. And I'm pleased to share that we here in Alameda County, with our partnership with all the FQHCs, we're ahead of the curve. As of September 1st, Recipe for Health is a covered service for Medi-Cal patients. You can prescribe Recipe for Health as a covered benefit, basically, just like you prescribe hypertension medicines or cholesterol medicines. Let me share with you where we're at in terms of the dashboard, recognizing we made a big jump to get us into September 1st, and there's been a lot of changes. So I want to acknowledge that and appreciate you all for riding through the changes with us. Just in August, our goal is 35. In August, as a clinic, we're at 19, dropped down in September to 11, really pumped it up in the last 2 months, October, November, have really started. We've seen a rise, and I think Dr. Sujimoto's brought the teams together to go over that. This is more of what it looks like on a weekly basis. So the whole clinic is averaging 3.8 a week. I think we can make this useful for you all, so you'll make more referrals moving forward. And the use case, the reality is, how do I make this useful and easy for you all to adopt? Given that most of us, especially the docs in the room, haven't had much training on food as medicine. In our 7 years of training, if you've averaged 7 years, the national studies show 4 hours to 7 hours of clinical nutrition total. Not even clinical nutrition, just total nutrition. It's mostly biochemistry. So we're going to start. Let's do the overview now on Recipe for Health. So really a few slides. When I'm trying to share what is Recipe for Health, I just say it's an integrative model of healthcare. So it's us in healthcare. We're waking up to using food as medicine to address 3 targets at the same time: food and nutrition insecurity and other social determinants of health, like transportation and whatnot. The bread and butter of what we do in medicine, which is chronic conditions and reducing those, improving health outcomes. And then we have an explicit focus on improving health and racial equity. We are doing this together. This is a partnership. And because of this partnership, we've been able to affect policy and systems changes. As I shared earlier, as of September 1st, your clinics, you as clinicians can prescribe Recipe for Health, and it's totally covered for Medi-Cal patients. And we at the county are covering it for everyone else who's not Medi-Cal. So don't worry about their insurance status, just do the right thing. We will have the supports in place. to make this happen. So what is it? This is like the what is a recipe for health? Well, every recipe has ingredients, and ours has 3. Many of you are aware of it, but many are new and have been kind of trying it on and hearing about it. The first is a food pharmacy. We partner with Dig Deep Farms, a local urban farm who grows the food regeneratively. This food is grown regeneratively and organically, and then it's provided weekly to people's homes, your patient's homes, when you write that prescription, weekly to their doorstep for 12 to 16 weeks. So we're breaking through and bringing food into healthcare in a structural way so that it's accessible and doable for you all. The next piece is, it's great to have food in healthcare, but what happens when my patients are exposed to foods they don't know? How do they actually change the life habits in their daily practice, in their daily lives? And that's what we have put forth with a behavioral pharmacy with our partnership with Open Source Wellness. They run group and individual health coaching that focuses on movement, nutrition, stress, social connection. There are 3 ways that we're doing this now. There's a health center-based group medical visit where at Ashby, you make your referrals there, and you have a provider, Dr. Daphne Miller, doing those groups for you all. So please refer to her. If the patient can't make Wednesday mornings at Ashby, there's also a county-wide group. It's in Spanish. There's a Spanish group and there's an English group. So don't worry. In the past, we said, oh, we can only do English. Now we can do Spanish. And if they can't make the health center-based group, they can go county-wide. And our referrals are showing right now, it's mainly English-speaking patients from Ashby. So again, want to clarify that so you all have the comfort in knowing that Spanish-speaking patients can be covered. And just a key piece, because we're talking about language, any patient can get the food. Arabic, Vietnamese speaking, Chinese speaking, whatever, Japanese speaking, any language group can get the food. There's no block there. In terms of the group and health coaching, for groups, we have English and Spanish. We also have individual coaching. When the patients can't do the groups, can't make a Wednesday morning, they can't do the county group at Tuesday in the evening, they want more of an individualized experience, we have that possibility too in Arabic and in Hindi. And we have other languages as well. So 2 parts, food pharmacy, behavioral pharmacy. And the last part is what we're doing today, which is the food as medicine training. And this is where we're shifting the mindsets, providing provider nutrition education in clinic and EHR workflow integration to make this as easy as possible, working with the health plans and working with the FQHC clinics across the county. Now let me pause and invite a few clarifying questions or any questions that are coming to mind, especially for folks who are hearing this for the first time. Feel free to jump on, do a comment in a chat. Okay, can I get a thumbs up so far from folks? Are folks tracking, making sense? Okay, yes, thank you. All right. It's hard to do this sometimes and I can't see everyone, but I appreciate the little emojis. So you're wondering, okay, cool, sounds like a great program. I can make a prescription for regeneratively organic food. This is like better than Whole Foods food, and it's delivered to people's doors. I haven't mentioned that the farm hires folks who are coming out of jail to give them a chance for employment and training, hires folks who have been victims of domestic violence, hires and trains youth as well in how to do this regenerative organic agriculture. So there can be driver jobs as well as pharmacy jobs and farmer jobs. And so when you're in clinic, you're thinking, well, what can I use this for, right? Well, anybody who has food insecurity, you can make the referral. Even though Medi-Cal doesn't quite cover that, we at the county have made the commitment. We're going to say any patient who has food insecurity. However, if they also have chronic conditions, please put them in. And the chronic conditions are metabolic conditions, bread and butter stuff that pediatrics, adult medicine, OB, midwifery, all of this can cover, right? Diabetes, prediabetes, overweight, obesity, metabolic syndrome, PCOS, fatty liver. I put an asterisk to prediabetes because there's some discussion right now. We're not sure if it's going to be covered. So that's why I'm going to encourage you, when you make a referral to Recipe for Health, put more than one indication. If you're going to use it as a treatment. So if the patient has diabetes and you're talking about hypertension, you can put diabetes and hypertension because food as medicine treats both at the same time, even depression, right? And we'll talk about that. Cardiovascular issues, hypertension, congestive heart failure, stroke, coronary heart disease, arrhythmias, lipid abnormalities, all your patients with triglyceride issues, lipid issues. And then we don't want to forget food and mood. So depression, anxiety. I've had patients when I was at Ashby who had eating disorders, and it was a great program to have the health coaching with the food coming in and coaching folks through. And then the high-risk perinatal conditions, I saw that we have midwives here. So your folks with gestational diabetes, diet controlled or not, preeclampsia, pregnancy-induced hypertension, these type of conditions, all covered. You have to you have to associate the diagnosis though. If you only put food insecurity, it won't be covered, but we'll figure out a way to cover them on the back end. And then HIV patients, cancer patients. We know that cancer patients often have poor nutrition, especially when they're going through chemo, asthma, COPD, so a lot of pulmonary conditions, GI issues like irritable bowel syndrome. And a big one for many of us, especially if you have older parents who are suffering from early signs of dementia. So there's a code, mild cognitive impairment, MCI, that's covered. Chronic kidney disease. Let me do a quick pause. Any questions so far? Who can make a referral? Thank you. And Willa, I'm not sure if I'm saying your name right, but the prescribers we have two groups of prescribers. We have traditional providers, medical providers, MDs, DOs, midwives, NPs, PAs, but we're also in our model expanding prescribers, and we say we have a group of prescribers without MAs. They don't have MAs affiliated with them. Nutritionists, social workers, behavioral health coordinators, CHWs, acupuncturists. I know you have acupuncturists, other staff who are touching patients, nursing, when they're touching patients and helping patients through chronic conditions. And if you can just update your name and all of that, that'd be great. So folks who are trying to figure out how do I actually make this happen, I'm going to give you two screenshots. There is an R4H food and health coaching initial referral. We built that through Epic. This is how it looks. All you do when you make that referral is you click accept. It's all pre-populated. You do not have to do anything. You just pick the initial. Don't do the extended option. There's kind of a link. We're right now on initial referrals for 12 weeks. There's all this mumbo jumbo that we've already put in to help so that the health plan kind of make it easy for you guys, because we have to get authorization from the health plan. We're doing that. My team's doing that for all you guys when you make the referral. We're trying to make this as easy as possible. You don't have to fill out TARS. You don't have to fill out any piece of paper. You just click a button when it's the right thing to do for your patient. And this is the pre-populated language. Has one or more of the following conditions, would benefit from 12 weeks of what we call in the policy world medically supportive food. That's what this is, and nutrition services to improve, stabilize the patient's chronic condition. And then we list the list of conditions that I shared earlier. It's all there. So if you're in the middle of clinic, like, gosh, Dr. Chen said we could use it. I can't remember if it's that. Then when you make a referral, you can see it and it's all listed there. In general, it's a lot of what you do in primary care. As long as you're thinking, hey, I can actually use food for this. Let me try it on. Maybe the patient wants this as an alternative than just starting metformin or starting a new blood pressure medicine, or maybe it's in addition to your blood pressure medicine. So prescribers, this is the key point. There's actually two more slides on this, and then we're moving into the content of nutrition training. So prescribers, to your question, well, there's MD folks and the medical providers and midwives and whatnot, and then you have prescribers without MAs. They must associate chronic conditions to get to have this covered, right? If you want it covered by the health plans. So here's what it looks like. You have to associate diagnosis. We all know how to do this when we're in Epic. I just put a whole bunch of examples of things that are covered. I want to just emphasize again, only chronic conditions will be covered by the health plan. So put 2, 3 chronic conditions when possible, just so that we cover all bases. And the key piece is, if they're food insecure, go ahead, put them in. Just know that it's not covered by the health insurance if it's food insecure by itself. And so for example, say you have a patient who has none of these chronic conditions, but they have food insecurity, go ahead and put that. We on the back end will figure out a way to cover those patients. That's our commitment to taking care of everyone, no wrong door. We're working with the state to have them include food insecurity because we know that this is a precondition to many chronic conditions. The example I give is if you're food insecure, you have a 200% increase in developing diabetes over time compared to someone who's food secure. So it doesn't make sense for us if we're trying to think upstream in our clinical practice to wait for people who are food insecure to develop these conditions. And that's what we're holding right now. We're going to make that commitment, but help it make it easier because these are limited funds for the food insecure only patients. If they have a chronic condition, depression, whatnot, and you're using R4H for it, just put it in. All right. Next piece, the final kind of nuance. Again, I'm trying to jam pack a bunch of operational things with the content, is the interim note. So all of this back here is in your SOAP note. You do this, it's automated, it goes through, we're good. Sometimes though, you'll have an interim note. You call a patient, a progress note, you're writing a progress note, a lab comes in and you talk with the patient and you say, wow, we have this great program. In addition to titrating your meds, I can do this, or instead of. In your note, this kind of quick note, all you need to do is mention two things. Because if you don't, the coders at the health plans will look and they'll deny it. And so it's not hard. It's basically in the note, say what the patient has, like diabetes or depression or obesity, and then put a status. And what I mean by status is a status that demonstrates the condition is not at goal, even if it's improving. Because the health plan has been clear, if the condition is normalized, then the health plan may not cover it. So if the patient has examples, diabetes, not just put diabetes not well controlled, and then you make a referral, referred to R4H, or diabetes status post hospitalization, or diabetes poorly controlled, or diabetes poorly controlled per recent labs. You're not even required necessarily to put the lab results in. If you do, it can be helpful, right? If you just happen to have the hemoglobin A1C. But the idea is that we're pointing the finger to the rest of the chart through this, so that if there's an audit by the state or by the health plan, they'll say, oh yeah, this patient had diabetes, wasn't well controlled, this is why the provider did that. Or obesity, same thing, worsening per BMI. You can put the BMI in, you don't have to. Or improving, this is the key thing. If you put improving, just say, but not at goal. Or depression, improving, but not at goal. Any questions on these tactical things you need to do in clinic? Okay, all right, enough of this stuff, right? We did the intro, we did the tactical stuff. Now let's get into the key piece. And this is what I'm gonna try to do in the remaining 35 minutes, 40 minutes. It's tough to do this all in one overview, but we're trying, okay? So I'm gonna need your feedback at the end on how I can make this better for you all. Recognizing I will be working with Dr. Sujimoto and finding additional time with you all, so that this will be helpful to you in your practice over time. So our approach, evidence-based nutrition research, clinical experience, we've been doing this for many years. Sustainability research, we look at the impact of the food choices and climate, and we incorporate traditional knowledge and wisdom. That will lead us to a healthy eating and practice approach you can take with your patients. And each of my sections on these 6 steps I'm gonna go through with you all, I'm gonna go into the what, the why, and the how. So you have this, that you can use this in your 15-minute visit. All right, you all ready? We're gonna do a case now. And I'm gonna need, this would be wonderful if I could see people's faces and I could actually talk with you or interact. Thank you so much for showing up. So this is your patient, Mrs. C, 48 years old. I want you to help me with my upper belly discomfort. I feel really bloated, especially after I eat. I've gained so much weight since immigrating here. I'm sad and feel low energy. All right. So first question. Oh, and then you actually have the chart in front of you, and you see the following vitals: blood pressure elevated, waist circumference ratio. If you're doing it in clinic, is higher. BMI is elevated. These ranges, you may think, gosh, 120 over 80, that's ridiculously optimal. And these are guidelines from the AHA, ACC. And I think we in primary care get so used to kind of high blood pressure. We're like, we don't bat an eye. But what I'm trying to train you all on is to be sensitive, that the 130s, the over 80s is still elevated. 140 over 90, certainly hypertension. So we can kind of have gradations, early signs of badness happening in the body. The exam is well appearing. There's no thyroid issues, abdominal issues happening. There's no issues there. And then you happen to look at the labs. So first of all, how do you interpret this? You got labs here, and I'm saying the whole picture right now. When you quickly look at this, how do you interpret this? What's the underlying process that connects Mrs. C's subjective experience with her objective findings, her bloating, her weight gain, her sadness? This is where I pause and I listen to you guys. Chatted way, or put it in the, or just speak out. Any ideas? No wrong answer, no wrong door. We're thinking together, we're learning together. Even simple things like what do you see in the labs that are you're like, maybe there's an opportunity here.
I would check a thyroid.
Yeah. So I should put a thyroid here, because you're absolutely right, especially in the low energy. I will do that. And the thyroid is normal. TSH is normal. Thanks, Dr. Frankel. Okay. Well, hopefully it's piquing a question. I'm going to now drop into, especially for those who kind of think mechanistically, the next two slides go over that. Like, what's the underlying process, right? Because we always have, we in medicine break things out. Hypertension, you have some cholesterol issues, but what's underneath all of that? There's kind of a common pathway to this metabolic syndrome, but I don't want you to be worried about the definition of the metabolic syndrome. I want to use metabolic syndrome to indicate there's 5 indicators that you can look at when you see your patients and you start wondering, maybe something's going on here around their waist circumference and versus over height, or their weight, their BMI. You can substitute different things. There's some glucose abnormalities. Blood pressure is kind of riding high now. Interesting, the triglycerides are up and the HDL is down. Why is it always that pattern? This goes up and this goes down. What's the root of this drive, of this mechanism? Do folks know? So at my med school at Stanford, the person who discovered this is called Syndrome X, but now called metabolic syndrome. It also was called insulin resistance syndrome, is that it's insulin resistance. So insulin resistance is a driver for all of these. And then there's an excessive inflammatory component. And then for those who are always like wondering, how come triglycerides go up and HDL go down? The mechanism for all of this, or I should say for this part, this is really for those who want to understand that, and there's a citation here, is as your triglycerides go up, all that sugar-based food in your bloodstream, that gets deposited on the HDLs, and then it clears your HDLs. Your HDLs get used up and your triglycerides go up. So just a quick mechanistic thing for those who understand. But the bottom line here is there's this way of looking at the patients where you don't have to memorize it, all the 5. If there's any abnormalities here, start wondering about insulin resistance. This is how we think upstream to take care of our patients. So then the progression is, how do we connect all of that to food? Because that's a big driver. This is our typical SAD diet, standard American diet, all the goodies, if you will. We know this from med school, and for those who didn't go to med school or nurse practitioner school or midwifery school, as you eat these foods, your sugar goes up, your pancreas responds by releasing insulin to kind of absorb that sugar. But you do that, if you're eating this stuff 5 times a day, 10 times a day, over time, your insulin keeps on getting brought up and up, and your body says, I don't like that. It's like someone yelling at you. You start kind of closing your ears. You don't want to hear the yelling. You downregulate your receptors, you downregulate hearing. In the same way, your body says it downregulates. And so your body has to create more and more insulin in the skeletal tissue, in the fat, in the liver, and it leads to insulin resistance and excessive inflammation. So that's from here. We also have another input that's more fructose-based, a form of a molecule of sugar that that goes straight to the liver. So your Coca-Colas, your alcohol, I should have a picture of alcohol. This is an independent pathway. It's a fructose-based pathway. It causes fatty liver. When your liver gets fat, even if your outside is not, that leads to inflammation and insulin resistance. And then many of the oils we use and the foods we eat, the processed meat, the Crisco vegetable oils, these hydrogenated oils, those are pro-inflammatory mediators. That's why we've outlawed trans fats, right? But there are other processed oils that are beginning to show up as inflammatory. All of this leads to what we deal with in clinic. If you're on the behavioral health side, the cognitive issues, the mood issues, there's autoimmune stuff. We have all of the metabolic issues, diabetes, fatty liver, obesity. So that's the progression. So this is my last section on just like the underlying cause for Mrs. C. There's other issues going on, at least from a physiologic piece, right? There may be social history issues, family history issues, but there's something in terms of the food that she's intaking. Any questions on this? Or what are your questions on this? Okay. All right, we're gonna keep on going then. So my part of this training is to help you become a detective. Be like Sherlock Holmes. When you're in that clinic exam room, you can work upstream in the exam room. And so this is kind of your, if you just use a glucose over time, like this is your sugar over years, it starts popping up because you become insulin resistant. Here's your insulin curve. And when you see patients who have PCOS, there's a subsegment of them that are hyperinsulinemic. So this is really great for folks doing GYN, for women's health care, primary care, pediatrics as well. We'll sometimes see kids. Obesity and overweight, not everyone who is, quote, obese or overweight has a metabolic problem. There are folks who are actually heavier set, and this is where I think we in medicine, we go into fat shaming, and we really are unhelpful to our patients. We have to be a little more refined. There are patients who are heavier set, overweight, quote, by the numbers, but are actually metabolically healthy, and perhaps more healthy than me, who looks maybe thin, but actually I might have a lot of visceral fat. So again, the idea is be a detective. You may then see patients who have insulin resistance. They're beginning to show this resistance because their insulin keeps on getting pumped up all the time because they're eating 5 times a day, eating the foods that kind of increase their insulin, and you see elevated blood pressures. Maybe not quite hypertension, but then you might then see hypertension, prediabetes, fatty liver, and then you get your frank diabetes. So we have an opportunity to not wait 15 years to address diabetes, 10 years for prediabetes, even faster for kids who are developing fatty liver. We have the opportunity in primary care, when equipped, to think this way and to actually effectuate the change to move upstream. So what are you gonna recommend to her? She says, what do I do? Can you recommend a diet for me? So interaction team, can I see folks again? How would you answer Miss C? We got a minute of brainstorming. This is your patient at 1 o'clock. All right, so Dr. Sujimoto puts in a diet, a plant-based diet. Okay, thank you. Other thoughts? Okay, so whole grains, no added sugars. What about B12 then for the plant-based? So this is great. This is fantastic. So ask her if she would be interested in us referring her to this program. Thank you, Willa. That's great. That is smart. So here's the point that of this slide. From a patient-centered perspective, you want to first elicit where they're at and make the adjustments. There's ketogenic, there's whole food plant-based, there's Mediterranean, there's all these quote diets that you can try to adopt and use as background, but it's harder to just say, hey, just do this. It's not as well received. You can take the principles of that, and that's what we're doing in this kind of training, is to give you the principles to understand and navigate those different approaches and to incorporate them in very small, titrated, bite-sized pieces. So rather than saying, hey, just try this diet and then go look it up, there are 6 tactical moves you can make that incorporate a lot of those principles of those diets. So thank you for that. Yes, so I can't, M. Tafari, I can't remember the name, but yes, you can do, this is what I mean by tactical things. Replace the white bread with wheat, maybe. Well, let's talk about that, right? You only got 15 minutes sometimes, and you can't do the whole, let me give you the whole thing on Mediterranean diet. That will take the whole 15 minutes. So how do we do this tactically amidst all the other challenges that you are all dealing with? So first thing is just to understand, remember there's 3 paths. First one, the first objective, what to eat. And this is where most nutritionists spend their time. They spend 40 minutes with the patient. Let me tell you what to eat and what not to eat. And it's important. And we need to figure out how to do it in 15 minutes sometimes. There's the when to eat. And many of you now may have heard people talk about, well, what about fasting, intermittent fasting? That's all about the eating window and the frequency of eating. So that's part of our training. We probably won't get deep into that today. We're going to focus more on the what to eat in the remaining time. And then there's the how to eat, the actual mindfulness pieces, or understanding hunger curves, or compiling food versus cooking food, eating out, all of those kind of things. So when, what, how, or what, when, how, when you engage your patient, it just gives you a framework to say, okay, I think we're going to start, this patient seems they're interested in the when. So we'll just kind of do one small move there and see if that step lasts, and then refer them to Recipe for Health, and our health coaches will help them on those steps. All right, so here are the 6 steps. So you got the what, the when, the how. These are the paths. And now you have your actual steps. And so we're going to cover, I'm going to walk through them all right now, but we're going to go in deep, probably on 1 and 2 based on the time. And hopefully we'll see how far we get, but we have 3, 4, 5, and 6. These are going to be all tactical. What do you do? How do you introduce this? And the why behind this. So the first one is reduce sugary beverages. Seems kind of obvious, right? But let's kind of equip us with the why, so we feel more empowered and confident as to why this is important. Sodas, juices, and alcohols. And then replace. And you'll see that there's a pattern. Reduce something, replace with. You want to always not just take away, but to offer alternatives that are meaningful and useful and that are patient-centered. The second one is, and these, by the way, are steps. They don't have to be in this order. So once you have these as part of your toolbox, you can dance with your patient. They may want to start with the when, or they may want to start with the vegetables here, and then go to the sugary beverages. So second step, reduce starchy foods. Sugary foods is another way of putting it, but the baked goods, the stuff that many of us grew up eating, grains. So you asked about white bread or whole wheat bread. And there's kind of a harm reduction model, if you will, in doing this: pasta, potatoes. Center, and this is where Dr. Sujimoto said it in his recommendation, center the vegetables and beans, because most of us in our diets don't have enough of that. But sometimes that's really hard, because culturally, we may not just be a vegetable and bean, growing up familiarly in our culture around that. So that's why this approach says, hey, make the vegetables and beans taste great with healthy and essentially minimally processed oils, meat, fish, fatty fruits, dairy, seeds, nuts, spices. These are whole foods. We're not taking the micronutrient approach of fats, carbs, and protein. We're saying people at the end of the day pick and utilize whole foods. Let's not lose all of these opportunities to help make the veggies and beans taste great. So that's your what to eat, the first 3 steps. There's the when to eat, really 2 components: shortening the eating window and reducing snacking for addressing the frequency of eating. And then I'm going to share the evidence around this in a subsequent training. Mindful eating, the 3 C's: cooking and compiling. What's the difference? Contemplating and chewing. Some of your patients are ready to go there, right? They're kind of wanting that next level. They've done all this other stuff. And then the how to eat as well. The other piece, the last one: minimizing meals out, maximizing meals in, potentially with family or friends. This is your 6 steps. Now, I know in medicine, we're always given lists of things to do. You give your list of patients for sleep hygiene and nothing sticks, right? It's just a list. So I'm hoping in the work that we do together, we help turn this and make it alive, so you can actually utilize tactical moves in your appointments with your patients. Questions on this? I can't see you all, so I want to just do a quick check. Thumbs up, thumbs down, clarifying questions, feedback. Thank you, Dr. Franco, M. Tafari. Sorry, I don't have your names. It's in the chat, but I can't see. So if I mispronounce it. All right, let's go on then. Okay, so let's talk about the what to eat. Pathway 1, right? Quality and quantity. So Mrs. C says, or we say to her, in trying to assess, can we talk about what you ate yesterday? This is kind of your 24-hour recall. But notice that I'm specific. I don't say, hey, what do you eat generally? Say, what did you eat yesterday? It's typical kind of nutritionist 101 stuff, located in a specific time so people can remember. Warning, as a primary care doc, when I started doing this, I was like feeling, oh my gosh, this takes forever. And I'm writing down all this stuff. I'm like, how do I make sense of they ate this and that? I have no framework, no idea. So as part of the change, recognize in the beginning it's a little uncomfortable. You don't have to do it on every patient. But it's one way of just getting a baseline sense of where the patient is. Many times what we eat in one day is what we eat in many days. Not always, but often the case. So she says the following: breakfast, lunch, dinner, dessert, and snacks. Give you a chance to read it, to digest it. So what do you see? What is she doing well on? Quick reactions. Strengths-based approach. Where is your patient doing well?
She's eating 3 meals.
That can be helpful for some patients, especially who don't have access. And it could be unhelpful for some patients if you're using the when. So, but it's a good starting point. Yeah, she has 3 meals. Sometimes you can do 2 meals.
She has some variety.
Variety is good. Yeah, that's great. Thank you, Julia. And thank you, Allison. So these are good starting points. What are some low-hanging fruit? What are 3 low-hanging fruit that you could make 1 tactical change on or 2 tactical changes on when you look at this diet? I see a smile on your face, Dr. Sugimoto. You want to say something?
It's always the juice.
The juice.
That's right.
The Sprite. Yeah, these are simple. Like, imagine switching that out. So we're going to talk about the science behind that. But yes, thanks for noticing that. Anything else, team?
The white rice could be simple, like brown rice.
Yeah, that's a great one. So we can do substitutions with white rice. Right. Fantastic. So this is just to whet your appetite. All right, we're going to jump in a little now. So I talked about the what to eat, 3 tactics. And we're going to focus on the why behind the reducing sugary beverages, the what, and the how, so that you can walk away from today's training, not just kind of giving a patient a list, but understanding it and helping to dance with them and recognizing that this is tactical stuff that's just as powerful and potentially more than adjusting your metformin from 500 milligrams to 850, or then titrating your depression medicines or your blood pressure medicines. Not to say it's the same, but these are sometimes more powerful, sometimes they work in conjunction. Go ahead, Dr. Sugimoto.
One thing that's challenging for me when talking to patients about what they eat is, on the surface, the ingredients they have are seemingly healthy, but then when you dig in, a lot of what they're buying are convenience foods. And so things that are actually loaded with high fructose corn syrup for like preserving, even like the rice, right? Ready-made rice is loaded with things like millet jelly or something.
Right.
And that's actually a big source of like these extra calories and as well as these inflammatory foods. But it's really hard to do that briefly. And I've just been struggling on how to do that more succinctly.
Yeah, I love the question, because once you dig into this stuff, once you're aware, then it can almost seem overwhelming. You're like, oh my gosh, I'm just dealing with the ready-made rice, but what about everything else that I'm not talking about? And how do I actually make that change? So I'm going to give you a few tips as we go through this on frameworks and potential ways to do it. But recognize, even if you made that change, that is a powerful change, because if these habits are done every day and you can change that habit, everything we eat and put on our body is information for our DNA to express proteins and to have expression down an anti-inflammatory pathway or an inflammatory pathway. So the question is, you get it, and you're trying to figure out, how do I do this effectively in a short amount of time, right? So hopefully we'll talk about that, but this is what is going to be challenging about today's overview, because usually in the subsequent, we'll actually we'll talk about it as a team, say, hey, what do you do? What do we do? Here's some recommendations. But let me see if I can get to some of that by first giving some content. Love the question. So let's talk about sugar, right? Do you all know what the recommended added sugar per day maximum is? Okay. For adults, we adults, around 6 teaspoons in a whole day of added sugar. Now, I put the teaspoon picture here because it's important for us to understand the conversion from teaspoons into grams, because once you explain it to patients in teaspoons, they can visualize it. But once they start tracking, well, how much sugar I'm having, they don't know if, when they read labels, and I'll teach one way, like how many teaspoons that is. They look at grams. So adults at 6, how about kids? Do you all know? Especially those who have kids. Children, none before age 2. Depending on age, 3 to 6, that's still high. This is the technical guidelines, right, from WHO and other places. I actually like to reduce this even further, because I think 25 grams for your 12-year-old is a lot, especially if you're saying that's okay for adults. But I'm putting the kind of guidelines there, and then you can make adjustments. But the point here is 1 teaspoon is 4 grams of sugar. 1 teaspoon is 4 grams of sugar. You're not going to talk, you're going to talk in both. You're going to toggle between the two in the following manner. So understand that. Remember, 1 teaspoon is 4. And how do you remember you're 25? I just often say, hey, you're forever 25, right? Everyone says, how old are you? Well, I'm forever 25. So hopefully a nice, easy way, you're 25. And then children, half of that, 12. My kids, we go even less. So just as a basic starting point. Now, why? Here's the why. So sweet drinks, sugary beverages are the greatest source of added sugar in the US. Now, this is a complicated table, but the bottom line point I'm trying to say here is on this N. Haynes study, soda, energy, and sports drinks top even desserts, fruit drinks, candy, dairy desserts, so the different types of desserts. Let's just give an example. For 12-year-old, if you have a 12-year-old, the average is 10 teaspoons of sugar. How many can adults have again? Per guidelines? Quick reaction. Hopefully I'm
6.
there you go. Thank you, Dr. Marino. So 6, if we're just going by guidelines. So teenagers at 10, look at the percentage of the total of their total added sugar of this beverage. It's 41% of their total added sugar in the day. I mean, and these are different guidelines, but that's a lot. There's a lot of sugar going in. And if you just can manage this piece, you're already helping the body metabolically. So some info about sugars and drinks. No effect on satiety. That's why you can have a big gulp and still feel hungry and still want more. Chemical additives, caffeine in some of these products. Obviously, they increase blood sugar and insulin resistance. And then many people think, well, what about the sugar-free stuff, doctor? Can I do the artificial sweeteners? It's sugar-free, no added sugar. But they actually increase insulin resistance via gut health and the microbiome. And again, we can do more deep training on this later. There's an overview. And then the fructose, one of the monosaccharides in sugar, can directly hurt the liver, go straight to the fatty liver. So this is UCSF Sugar Science if you want to read more about it. So the tool that I use in clinic all the time is what I call the 24-hour added sugar journal. And I've done this and people's eyes become, they open up. They're like, oh my, wow, really? This is how much sugar I'm drinking and now I know how to interpret it. So it's simple. It's saying, read the label, and I tell my patient, pick one day of the week and read labels for that day on any packaged food that you have or any drink you're having. And don't get confused on this nutrition facts. Look at really one thing. Look at the total grams of added sugar. Don't worry about the calories. Don't worry about everything else. Look at the serving size too, but at the end of the day, just one thing. And this is what I mean by tactical, easy to do. And then write down how much added sugar. And I say, hey, if you're an adult, you're forever 25. That's your goal, if we're going to use that as a goal. Or your children, think 12, right? Half. You do this, people's eyes open up because they didn't understand how to interpret the landscape of food that they're consuming. So a simple 24 added sugar journal. I have like smart phrases I use in Epic, and I just put that and it's there, and then they have information on how to do it. You can also look at ingredients. Here's I like using this image. So here's, and this will come out in the, we'll send this up as a PDF. So you can somehow, I don't know if you can put these QRC codes in your after visit summaries or not, but if you want to check out, this is just an image of this. Any questions on the 24-hour sugar tool? Good. Okay. So remember, what is the other part of understanding the landscape is, well, what is sugar? There's a lot of different names for sugar. It's kind of the great masquerader. Anhydrous dextrose to brown sugar, agave, nectar, corn syrup, which Dr. Tsujimoto mentioned. Honey is sugar, right? Molasses, raw sugar, fruit juice concentrate. There are 61 names, types of sugar out there in our products. So then let's dig in, and I got 6 minutes to close out this section. So are any of these drinks that you all have? I'm seeing some smiles. So do your own 24-hour sugar tool. This is 100% orange juice. Doctor, I mean, I drink 100% orange juice. It's great, right? No chemicals, it's all 100%. 9 teaspoons. So if you're a kid and you're supposed to have 3 teaspoons, you're at triple that. You're an adult at 6, you're over it just with that one 12-ouncer. Sports drinks, even more, or relative more. Energy drinks, 13. Lots of sugar in our environment. This is the standard American diet, the SAD diet. Look at Coca-Cola, 39. You're way over your typical day. And if you have diabetes, and I mean, I've had patients, and at Ashby, when I was seeing patients there, 110 grams a day of just from their beverages. Every day you're drinking that 5 times a week, over years, you're going to start developing all the fatty liver and all of the other issues that arise. Small little pearl, 100% juice. It may not say added sugar. It'll just say total sugar, because sometimes it's not added. It's just the sugar from the fruit, but all the fiber's gone. So it's it's not nature's candy anymore. Nature's candy is an orange, not an orange juice, because the orange has fiber all over it. So that's the one beverage you'll need to look at total sugar. Questions?
When you think about alcohol, do you add that to the total sugars, added sugars for the day?
I do. And I think alcohol is insidious because, there's the talk about cardiovascular health, maybe depending on the J point curve and how much alcohol per day. But that's from a cardiovascular perspective. From a brain health perspective, there's not a lot of help. And then from a liver perspective. So overall, we blend in certain pieces, but I will consider that as well. So can we talk about what you ate yesterday? Knowing what you know about sugar, help me identify the main sugary pieces that we can make adjustments on. How about this one? Right, that's an obvious one. I know someone in the chat said they drink a lot of sugar in their coffee. Orange juice, right? Sprite. So this is a dance with your patients, because you don't want to be just negative Nelly, take away all this and no quote fun in life, whatever. So you want to have really viable options. And so maybe it's a conversation. Again, this is tactical. You may think, God, it's such a waste of time. I should have a nutritionist doing this. Actually, this is medicine. You get that patient off that sugary beverage and shift them to an infused water with orange for the taste. That's massive metabolic benefit. The sugary cubes, you go to black coffee or green teas or the teas, lots of benefits there. So there are tactical things you can do. It's worth the time to do it, and then refer to us, because we will amplify that over time. 12 weeks with us, 12 weeks of getting this amazing food. Use your 24-hour sugar journal. So we just finished this first section, and because of time, we're not going to be able to do step 2. This was just step 1. But I hope I've whet your appetite enough that you'll want me back, and we'll figure out more times to actually make this to kind of grow your practice and your approaches. I'm going to, in the remaining time, take questions, but also I'm going to put up a post survey because I want your advice and your support on how I can make this more effective for you. Maybe I was on the mark, maybe I wasn't. So super open to feedback. For those of you who have done the training 2 years ago, you'll see that we've made a lot of adjustments, really based on learning from everyone. How can we make this effective? There is not a great curriculum out there in the world on how to do this. And so questions, and can you guys see me? Yeah, go for it. Questions and chats. How about always having healthy fats and protein with sugar? Yes, so combining is really key, right? So that's another way of doing it. We'll get into that when we talk about the other foods. Let me just share my screen here with this piece, just to remember as a target. Oh no, sorry team. This is the challenge of, I had other content, but I wanted to see how far we could go. So other questions while I do this, you're getting a sneak peek. 61. Other questions? Okay. So just remember your goals for your clinic in terms of deliverables, 35 a month, about 9 per week. You have 9 providers here potentially. It's one. I mean, it's super easy to hit this, right? If this is on your mind and you find this as a useful tool. So it'd be wonderful if you could commit to your own personal goal. But the key piece I'm hoping for is also this, to give us feedback on this piece. So if you can flash the screen while we close this out, put this in, how would you rate the quality of today's training? Scale 1 to 5. What's one thing I can do differently to help you do the work of primary care on the ground? Not everyone knows what the portion sizes are. We'll be talking about portions. Portioning that with sugar was the first piece. Nuts and all of that. Other questions, team? I want to respect the time. I know that you have clinic to get to. I want to thank you for the opportunity to work with you. I want to thank you for your partnership. Lifelong has been an amazing partner in this work. We are across the sister clinics and we're growing. And the feds, the White House teams, they've been very interested in what we're doing together. So we're really on the edge of kind of doing things differently and bringing food into medicine. All right. Thank you so much for being here.